Dr. Tanya Choudhary next. Yeah, please. Emulsification surgery. Dr. Tanya Choudhary, co-authors Dr. Renu Dashwana and Harsh Bharata.
Good morning, respected judges, seniors and colleagues. I am Dr. Tanya Choudhary, third year resident from Himalayan Institute of Medical Sciences, and I am presenting a case on a study of paired incision in phacoemulsification surgery. My guide is Professor Harsh Bahadur and co-guide is Professor Renu Dashwana. Now we all know that cataract surgery is the most commonly performed refractive surgery in the world, and astigmatism is a very common refractive error that we see in our day-to-day life. The prevalence of preoperative astigmatism is 86.6%, of which 35 to 40% have corneal astigmatism greater than 1 diopter and 19 to 22 have greater than 1.5. There are several options present to remove this corneal astigmatism or reduce it during cataract surgery, which can be limbal relaxing incision, incision made on a steeper axis, a paired incision made opposite to it, and a more expensive technique of using toric intraocular lenses. Thus, our study is basically focusing on evaluating the efficiency and complication of paired incision in controlling corneal astigmatism during phacoemulsification surgery in a cost-effective manner. My aim was to evaluate efficiency of paired incision in controlling the corneal astigmatism in phacoemulsification surgery and to assess the complication of these incisions. In a period of 12 months in our Himalayan Institute of Medical Sciences, an interventional study was performed in 56 eyes. Our inclusion criteria had 30 to 80 years of people included. Vertical and horizontal astigmatism was calculated and it was in between 1 to 3 diopters. Exclusion criteria included that astigmatism should not be less than 1 or greater than 3. Oblique astigmatism, pre-existing corneal scar, keratoconus, or previous ocular surgery, trauma, subluxated cataractus lens, or complicated cataract surgery were also excluded. Basically, all patients underwent detailed ophthalmic evaluation of visual acuity, diffraction, slit lamp examination of anterior and posterior segments, measurement of axial length, measurement of corneal curvature by manual keratometry. All patients that were included underwent phacoemulsification surgery. During the surgery, a primary incision was made on the steeper axis. And after completion of intraocular lens implantation, the anterior chamber was filled with viscoelastic and another incision was made right opposite to the primary incision. Now the keratometry difference was evaluated at 1 week, 1 month and 3 months after the surgery. This is a basic picture showing that the primary incision was given at 12 o'clock and a paired incision at 6 o'clock position when the steeper axis was the vertical meridian. A total number of 56 eyes were taken, male were 25, female were 31, the mean age group was around 62.8 and majority of the patient lied between 61 and 70. Our vision, preoperative vision evaluation was that 6x6, maximum number of individuals that was 16 had 6x60 vision. The preoperative refraction in the operated eye in the study population, here only the positive lens in the 90 or 180 degrees were taken and the spherical equivalence was excluded. So we can see that the maximum number of individuals, that is 33, 58.91%, was between 1.25 to 1.75 diopters. Now, since we have taken 1 to 3 diopter keratometry difference, we see that the majority of the cases were between 1 to 1.25, that was 46.4%. Now coming to 1 week post-surgery, we see that the vision improved till 6 by 9, that was in 32.1% of the individual. The refraction correction, the maximum number of individuals now had less than 1 diopter, that was 76.78%. The mean refractive correction was 0.77 plus minus 0.45 standard deviation, which was clinically and statistically significant comparing to the pre-operative evaluation. The keratometry difference, we can see the maximum number is between 1 to 1.25. Now we see that we took the 1 to 1.25 as a parameter where 26 individuals were there pre-operatively, and now the individual out of this 26, 12 had between 0.5 to 0.75 and 8 to between 0 to 0.25. 6 patients remained the same. The mean was 0.76 plus minus 0.5, which was again statistically significant. We also found that the patient developed endophthalmitis but was managed thoroughly, attaining a vision of 6 by 12 by 3 weeks. That patient was also included in the study. Now vision assessment at 1 month, we can see there are maximum number of individuals had vision 6 by 6. Again, almost 85.71% of people had refractive correction less than 1 diopter. The mean difference when compared was significant statistically. The keratometry difference post-operative 1 month, again we can see the maximum number of individual was between 0.5 to 0.75, that is 44.6%. The mean difference was again compared to the pre-operative evaluation, which was clinically significant. The vision again was 6/6 in maximum number of individual, refraction less than 1 diopter, mean was statistically significant. And the keratometry difference, coming to the keratometry difference at 3 months, it was observed. Now the mean again compared to the pre-operative evaluation was statistically significant. Also there were 56 patients taken pre-operatively having keratometry difference of 1 to 3 diopters, 30 out of which had less than 1 between 0 to 0.75 by week 1, 44 at month 1 and 45 by 3 months respectively. Also observed that 0 keratometry difference was seen in 7 individuals by week 1 and 10 by month 1. Conclusion: a simple paired incision applied opposite to the main incision on the steeper axis of the cornea in phacoemulsification surgery easily improves corneal astigmatism without any extra skill or instrumentation. A proper preoperative evaluation to estimate which one is the steeper axis in the cornea is important to determine where the incision, primary as well as a paired incision, should be made. In the era of only lenticular astigmatism, reduction in corneal astigmatism can also be achieved with the same instrument using a keratome in a cost-effective manner. Surgeons should also be aware of the risk and complication of a paired incision, thus not selecting patients with pre-existing corneal abnormalities, or should be aware of the wound leak, which can also, or if there is no proper hydration, it can also lead to endophthalmitis. Take-home message is a paired incision on a steeper axis during phacoemulsification surgery is a simple, effective and cost-effective way of correcting corneal astigmatism. No extra instrumentation or skill is required, and the same keratome can be used as a cheap, safe and reliable method. These are the references, and thank you.
Which instrument were used for doing keratometry?
Sorry, sir?
For doing keratometry, which machine?
So a manual keratome was used, a manual keratometry machine that is used, that we use for K1 vertical keratometer and horizontal keratometry, when we assess whether it is between like 44 to 46, but which one is the steeper is our main aim.
And you said only single paired incision.
Yeah.
Suppose the keratometry difference was 1 diopter or keratometry difference was 3 diopter. So how you can correct with the same type of the incision?
So our pilot study was Dr. Uday Devgan sir, and it is said that by making incision, 1 to 2 diopters can still be corrected but not beyond 3 diopters. So my study included between 1 and 3, and the correction was taken whether it is less than 1.
Suppose the diopter difference is 3.
Yeah.
And diopter difference is 1. In one eye, one of the eye of the patient is 1, another is having 3. So how could you, was there any criteria for the depth, length or something else?
No such criteria. The same depth, same length, say 2.8 disposable keratome was used with all the patients. No differences were there in the patients having 1 diopter difference or 3 diopter difference.
So you think that the same incision will correct 3 diopters, same incision will correct 1 diopter?
So normal incision based, if we talk about corneal astigmatism correction, if it is incision based, it will not correct the 3 diopter astigmatism as per the previous studies. My studies did not have individual till 3 diopters. It had maximum 2.25, and that was actually corrected till 1.
Right. Thank you.
Thank you so much.
Right. Thank you. Thank you.